welcome, and thank you for joining me. I have Dr. Renia Dotson and her husband, Dr. Wayne Dotson, with me today. And I'm just going to briefly introduce you guys. Dr. Renia Dotson attended medical school at the University of South Alabama in Mobile, Alabama, and her residency in surgery was at Boston University, and her fellowship in colorectal surgery, the colon and rectal clinic in Houston, Texas. And she completed her MPH and MBA degrees recently at the University of Alabama, Birmingham. She's also on the Board of Regents at the University of the South, which is our alma mater in Swanee, Tennessee. And Dr. Wayne Dotson is a medical doctor as well, and he attended medical school at the University of South Alabama in Mobile, Alabama. His residency in orthopedics was at, correct me if I'm wrong, Boston University?
Yes, it was.
Okay, and did you do fellowship after that?
No.
Okay. Okay. I think I got it. So again, welcome. And the reason why I'm doing these interviews is because a few weeks ago, I noticed that nobody was talking about the effects of the coronavirus on people of color or melanated people. And I was concerned because I was anticipating that it was going to hit people of color harder than it's hitting the rest of the population. So I wanted to get some interviews with people that I know are experts in their fields, which you guys are. And so I'm just going to ask a few questions and you guys can go at it. So what do you do in your daily practice, like on a day-to-day basis? I'll ask Renia first, Dr. Renia.
My practice is primarily around prevention and treatment of colon and rectal cancer. I do a lot of screening work. I am also a general surgeon and take general surgery calls, so my practice could vary on any given day based on what comes through the emergency department or what works in my office. But back to the colon and rectal practice, I'm also actively involved in an initiative here in Mississippi, which was the 70 by 2020 initiative, and it was to have 70% of the population of Mississippi screened for colon and rectal cancer by this year, 2020. Of course, COVID has now made that look a little different, and where we go with that probably still remains if we extend it or if we just take the data that we have. That's all up in the air right now, but that study was being headed up by Dr. Roy Dewey at the University Medical Center in Jackson. So.
And how about you, Dr. Wayne?
My practice is in general orthopedics, so I see anything from osteoarthritic patients in our older population to sports medicine, do a little bit of basic peds trauma, and then of course I take trauma call, which puts me in line to take care of our trauma patients in the region as well.
Wow, I didn't realize that. What percentage of people of color or melanated people do you usually serve? And again, I'll start with Dr. Renia.
I think it's probably about 70-30, I think. 60-40, 60-40, 70-30.
So 60 people of color? Or is it the other way around?
The other way around.
Okay. And Dr. Wayne?
I'd say I'm closer probably to 50-50 on a daily basis.
Okay. And are you expecting higher numbers of mortality and morbidity in your region and people of color? And why do you think that would be so? And I'll start with Dr. Renia again on that.
Yes, I think just by looking at our demographics overall, I think we have a good bit of disparity already in the Mississippi Delta. I don't think that will play out any differently with COVID than it does any other chronic disease that we face here in the Delta. I also think that our communities did not take it as seriously in the beginning as other communities have, and have not practiced social distancing. I've had several patients tell me they don't believe that the coronavirus is real. So given we were already behind the 8 ball with the known disparities, and those same socioeconomic factors and social determinants of health will be at play in this pandemic as well.
And just to get a little more information, are you noticing a pattern in the people that don't believe it's real? Like, is that people of color? Is it other people? Like, what would you say?
It's across the board, I would say.
Wow. Okay.
I think it's been pretty much from all economic groups and from both racial groups. I think they looked at this initially as it was happening in the big cities, it's not going to get here. I think by the time they realized, oh my God, we got cases in, a county away or 2 counties away, it was late in the process. They were thinking, well, we don't have people going back and forth traveling to China. Yeah, but you do have people traveling all around the region, and the whole region has reported cases.
Yeah, you guys are in the Delta of Mississippi, whereas Dr. Renee mentioned there's a lot of issues with the health disparities going on down there anyways. Do you anticipate problems due to lack of insurance coverage? You can...
To some extent there will be, but a very large portion of our population is uninsured or underinsured anyway. So it's not like that this will affect them any harder than any other common disease does. So I think that may have some bearings on it, but probably not as much as in some other areas. Not any more so with this disease than it would with any other chronic disease they face.
So Dr. Wayne, is the uninsured population high down there because of unemployment? Like, I didn't realize that about your region.
Yes, it is high because of unemployment. This has been primarily an agricultural region. Agriculture has decreased its workforce over the last couple of decades since we've been here. I think we've been seeing that continually happening. A lot more automation. There's a lot more machines doing work that used to be done by hand. So you have seen that. We've lost some major plants. Even before this happened, we've lost some employment opportunities in the region. It does affect them also in that those people tend to hesitate on coming to the doctor. They tend to wait, because I don't want to pay for it. I'm in a situation where I only have so much resources or so much money to pay for essentials that, okay, I'm going to kind of ignore this until it gets bad. And we all have the order to stay at home when we're sick, but they tend to wait just a little bit too long in certain situations.
Wow. Yeah. And I think that's not only true there, but I think it's true here for our patients as well in the Northeast region. So Dr. Renee, you have an MPH and you study epidemiology at a graduate level. What is important for melanated people or people of color to know about avoiding and preventing COVID-19?
I think all of the CDC guidelines that have been set forth already need to be followed. Strict hand washing. I don't think that's necessarily a big thing for our population to put their hands around, and sanitizing things has not been very, very hard for them to put their hands around. What has been difficult is getting them to really buy into social distancing and staying home and only going out for the things that you need to go out for, and not taking your entire family to the grocery store to shop.
Wow.
When you pile 10 people into a car that's meant to hold 6, that's certainly not social distancing. And then you drive around and you take all of those people to the grocery stores. It packs the aisles and it increases the amount of spread. I think a lot of what happened is that we were listening to the wrong people and we're listening to the wrong messages. Early on, we made a lot of jokes and a lot of high-profile comedians made jokes about the fact that, oh, Black people can't get COVID because, you know, we eat chitlins and therefore we're somehow having immunity. And yes, we as a people are historically resilient, but it still doesn't mean we don't get these things, and it doesn't mean that we don't die from these things. And so I think we, in the beginning, did not take it as seriously as it could have been and should have been. And now some messages are embedded and become indelible, and then they're very hard to get rid of. And I think that's what we're seeing now. We're trying to undo words that you put out there. It's very hard. And I think that as healthcare professionals, we have to be very careful about the statements that we make at this time about COVID and the things that we stress. Also, we have to be careful with our actions about what we do. If we're saying social distancing, then we also too need to stay home when we're not at the hospital. We need to walk the walk and talk the talk. And oftentimes people are more willing to get more out of what they see us do than what they hear us say.
Okay, so Dr. Wayne, if a patient of yours gets diagnosed with COVID-19, what should they do now? And especially a patient of yours that may have just recently had surgery, because you guys are both surgeons.
Well, the most recent worries I would have with surgery is that means they may be compromised already, because right now we are not doing any elective surgery. I'm only doing trauma and infection. So if I'm doing those two things, there's already some immunocompromise going on. I think that we have a hotline set up through our hospital for them to call initially, and then follow those guidelines. The guidelines of, you know, if you have a high fever, you need to contact your medical professionals, your primary care doctors, and follow those instructions. From a surgical standpoint, I'm not really concerned at this point about wounds breaking down. It probably will slow their rehabilitation, as it's already been slowed some by this. But I'm not really worried about the surgical wound. At this point, of course, you're taking care of the whole person, trying to get them into an appropriate protocol, and they need to contact the surgeon and the internist or primary care physician that they use in order to get treated for their COVID-19 symptoms.
And Dr. Renee, same for you. You probably have the same recommendations, but I'll just add to that question, like if they're supposed to come to your office to follow up, do you have protocols? Like if people think they're sick?
Well, if the patient thinks that they're sick or having any symptoms, we recommend that they not come to the office. They do follow up with their primary care physician or call the COVID hotline to see if they meet the guidelines for testing. If they do meet the guidelines for testing, then they are contacted if the test is positive or negative, and there are protocols in place. There's a triage system in place for that, for who gets empirically treated with Plaquenil and Azithromax currently. And they're given a prescription for that, are told to either self-quarantine or if they're sick enough, then they will be admitted to the hospital. They do not come to our offices. The other option for that patient would be a telemedicine visit. But we check temperatures at the door. We check people in from the parking lot. So if a person is experiencing symptoms and they call us, we would not have them come to the office at all.
Mm-hmm. And do you know where testing is going on, like in your region or in your area?
Yes, our hospital has set up a drive-through testing center at our business office, which is off-site from the hospital. It is called the Pavilion, and it's across the street from the YMC. It's a wide open area, and you can do they do drive-through testing there. For more individuals who are experiencing greater symptoms or higher level of symptoms, there's a special segment of the emergency department that is designated for COVID patients where they don't encounter other patients and it's isolated, and they can be in quarantine. And then there's a special protocol if they're sick enough to be admitted, where they minimize their contact with the rest of the hospital. Our COVID unit is, we transformed our endoscopy suite so that it has its own entrance, and it's actually can be cordoned off from the hospital, from the regular hospital, which it is. And so all of that is in containment measures to keep those patients safe, and the workers and the other people in the hospital that may have to come in contact with them as well.
Wow, okay. Sounds like they've gotten organized in your region, which is good. From a policy perspective, I'm going to ask you to put on your MDA and MPH hat. And what do you feel is important for hospitals and providers with practices to do to survive this pandemic?
For surviving this pandemic, I don't think there were any policies that could have been foreseen or put into place to adequately address what we're facing now. However, if you are making policies in light of what's going on, I think those policies have to be flexible and have some nimbleness in it, because what we know is changing so rapidly now that anything chiseled in stone will probably be outdated by the next 2 days or the next week. And so flexibility and nimbleness will be the two characteristics of any policy right now. I think that there will be more policies to come when we're on the other side of this. But rigidity in where we are now is not going to be helpful at all. So flexibility.
And again, asking you for your expertise regarding ethics. I can tell you that I'm licensed in a few states, and where I'm licensed, we had meetings, virtual meetings this past week, and I'm concerned because they have stated to us that basically the medical boards are still holding us to the standard of care in our delivery of care. And despite the fact that it's impossible to deliver the standard of care, we don't have the proper PPE, and I'm hearing about shortages of supplies across the board for certain things, including ventilators. And there's also a shortage of personnel. So it sounds like in some cases, like in areas where there are huge numbers of people in the hospital, that patients are not being covered in the normal way that we would cover them. For instance, I heard numbers about ratios with nursing, like 30 patients to one nurse, which is way above what we would normally see. So I'd like for you to comment on that, because it feels to me like this is putting doctors and nurses like in a corner. It's opening us up for liability where we have no control over the situation.
Well, as far as the ethics is concerned and the standard of care, I read those same guidelines and those same segments. And I, as a surgeon, I didn't interpret it that way. Kind of in those broader terms, I interpreted it in a different way, because even though COVID is happening now, the same diseases that we treat every day are still happening. They're still happening at the rate that they always happened at, and people are still experiencing this. So the majority of my patients are not COVID patients. So as far as delivering the standard of care, physicians in the US are experiencing scarcity like we've never experienced it before. We've never had to decide who gets what or when they get what, and on such a low level. We're used to advocating for it, and it's happening. So in the face of scarcity, I think that the standard of care must be applied and has to be applied. And for me as a surgeon, what that means is that I have to decide who can have surgery and who cannot have surgery, because we've been mandated not to do elective cases. And we have a tier system that gives us a system of what cases are considered to be totally postponed and not done, and then others that have to be done on an urgent basis. So here is where the standard of care becomes very, very important, and it's imperative that it's applied to each patient and to each patient individually, because one has to ask herself, can this procedure wait? Or does this need to go on urgently? And so my rule of thumb, what I do is, say if I were to diagnose an early cancer or had a patient who was bleeding or something, I apply the standard that if this patient asked me if they could go on a vacation for a month or 3 weeks in my normal day-to-day practice, would I allow it? If I would not allow it, then they go on and we have that procedure and we proceed with that procedure. The other thing is that physicians are also right now in very unprecedented times, in that most of us as surgeons are twiddling our thumbs because most of what we do is elective, so we don't have anything to do. And I think now the standard of care is important more now than ever, because we have to protect the most vulnerable among us, and that is the elderly, the people with comorbid conditions, the uninsured, and the underinsured. So we cannot falter into making decisions about care and what procedures we do based on those things, being discriminatory about comorbid conditions, where we only do the healthy people that we think are going to do well, or whether we only do insured patients, because most of us now have very little volume or income coming in, or whether we do the underinsured patient. I don't think any of that, the standard of care does not allow us to take any of that into consideration. And I definitely think that at this point in time, it has to continue. The standard of care has to continue. Now, most of our patients don't require any extra PPE, and I understand that, but I read those recommendations and those statements to mean the non-COVID patient. And as far as the medical legal standpoint, from a medical legal standpoint, yes, that is something that we always have to deal with. But if we were really, truly, truly worried about avoiding a lawsuit, then we'd never do a procedure. So.
Wayne, Dr. Wayne.
It's an unprecedented time, as she said. I think when you're dealing with limited resources, we have to understand this is not like a normal situation. All of us, surgeons, internists, nurses, everybody. This is not a normal situation. This is all hands on deck. It's a war. There's triage involved. That's not pleasant. We're used to just treating people and moving on. We have to understand that normal ratio of 6-to-1 may not be possible when our hospital is getting overrun. We have to allocate our resources where we can. The standard of care has in some ways been altered by the situation, okay? It's not a matter of, am I going to walk away from something when, I can't, okay? It's a matter of, these are the resources I have. This is what I have available. This is the best use of them. This is what we have to do. As far as the medical legal aspect of it goes, for me as someone who does a little bit of review for attorneys on occasion, I'm sure they're going to be suits out of this. I'm sure they're going to be suits out of this, because that's what they do. They're going to be people looking to file suits. I think what we as doctors have to do right now is manage our resources the best we can, do the best we can for our patients, try to maintain both our ethics and our standard of care as best we can, and then let the chips fall where they may. Now, there's always an attorney, an expert, or someone out there willing to file a suit. My hope for my colleagues and myself would be that, given this situation, the other people involved would understand that, hey, this guy didn't have an extra ventilator to just put someone on who was marginal. He had 3 people who were critical. He had 2 ventilators. He's got to make an assessment on who's going to benefit the most, or who's going to be the most responsive to the treatment. That's a difficult decision. These are difficult times for us as a profession. but those are the things that we're going to have to do to try to maintain our profession going forward.
Yeah, and I'll just comment about the ventilators. I heard in the news this weekend that New York is doing that triage process currently, that they've started kind of practicing it or gearing up for the coming week, is what it sounds like.
Yeah. They are. You've heard instances where they're being told that, if someone is not is resuscitable, they can't resuscitate them, don't bring them in because we don't want to expose people. It's an unprecedented situation. We just have never been in this situation. We are used to it. We all know that, okay, the ICU is full, but there's something we can do in the emergency room. We can bed them in the emergency room. We can bed them somewhere else until we get something. We've all been there and done that. This is a overload in a situation like we've never seen before, where you need 3,000, I'm just throwing a number out there, and you only got 2.
Yep. So what are the aspects of shelter in place where you are in Mississippi? Either one of you can answer that.
Well, we're in shelter in place. You have now, it's statewide. Governor made that decree, that executive order on Friday, starting at 5 p.m. And so you're only out, only essential personnel should be out. You could go to the grocery store, and that is it. Essential businesses here were listed as healthcare workers, grocery store workers, transport workers, bankers. Who else is on that list? And there were no public gatherings greater than 10 people. That was before, but that with the new shelter in place, that shouldn't be an issue, but it has been in the past. Is there anything else I left off that list?
I think that's essential manufacturing was one of the other things, but that's we've essentially gone to the same general guidelines as the other states that are in shelter in place. We haven't gone to a full lockdown, but we are being asked to keep our social distancing from others and to remain at home if you can.
Yeah, I noticed here that liquor stores are open, which I guess they're considered kind of like pharmacies. Do you all have that situation there?
I think it's more because liquor stores are listed under convenience stores, and it's hard to out a liquor to go, who has the time to go through and parse out which ones are liquor stores and which ones are true convenience stores and 7-Elevens and that sort of thing, because they sell beer. They don't sell alcohol, but they sell beer. They don't sell spirits. So I think that's where the gray line comes with liquor stores, and they kind of slide into a loophole there. Although you also, if you're looking at it from a totally ethical standpoint, do you really think it's a good idea to close all liquor stores, because you have a certain number of population that are alcoholics that have not sought treatment and don't wish to seek treatment, nor do we have time or the resources now to combat inpatient rehabilitation for alcoholics. And we both all know as physicians that DTs are very dangerous as well. And so you run the risk of, if you cut the population off cold turkey, you run the risk of a lot of people having DTs as well. So it's a balancing act on any of it that you enact.
Yeah, that's why I said maybe they're considered pharmacies. Jokingly, but
some is a pharmacy.
I didn't check the numbers for Mississippi this morning. Have you all had some deaths in your state?
We've had deaths in the state, but not in our county.
Okay. And do you know how many are in your county?
We got 31 as of Friday. I have not seen an updated list.
Okay.
Reported cases.
Reported cases, yeah.
Okay. Any other questions or comments that either one of you have about the situation?
I would just, warn all of us, as my wife said earlier, that, we are a resilient people. We live through a number of things. We believe we can survive everything. But as a community, we need to take this seriously. We need to take this seriously. It is something that we need to address our social distancing. I know that's not usually our nature in our communities. We tend to be out and about, particularly as things are warming up. But we need to make sure that we're following the CDC guidelines. The new guidelines of wearing a mask when we're in public, which is in certain countries that did that early on, has been very beneficial. Even a non-medical mask, a bandana, something. Keeping your trips out of the house. If you don't have to go, if it's not essential, don't go. Don't go. We have to adhere to these guidelines. The sooner we do this, the sooner we flatten the curve, as it were, and the sooner that this situation resolves.
And I think building on that, those of us who are healthcare providers and who are leaders have to be very mindful of the things that we say and the things that we do, because people are watching and they're listening. And it seems like one sound bite of bad news or not the best news or not the best instruction goes much further than a whole paragraph full of, or a whole interview full of consistent, concise medical data. So we have to be very careful. The tendency is to make light and to joke about it, but it's no joking matter now, and we have to be very careful about the message that we send.
Mm-hmm.
From the top one among us to those of us who are right here in the battlegrounds in the rural areas. So.
Well, I thank you both, because I'm hopeful, and I think that when I publish these videos, that it's really going to speak to our community, and that it's going to have a positive effect, because I'm getting the same message consistently from all the practitioners that I'm interviewing. So thank you so much, and thanks for taking time out of your busy schedule today.
All right, thanks for having us.
Thank you.